Yeah, recording.
Cool.
Shall I introduce it?
Yeah, brilliant. Oh yeah, that'd be great.
Cool. So yeah, I just thought with our like ever increasing presence in primary care that it is quite important that we are just admitting some other people, sorry. Yeah, I just thought it was really important that we are aware of this as a condition. So the presentation today is going to be on spondyloarthropathy. You may have heard it before as ankylosing spondylitis or spondyloarthritis. But yeah, I've just been recently doing some research into it. It turns out the prevalence is much higher than I recently thought. So I thought, yeah, let's do some learning on it. So I'll just share my screen with you guys. I think it's this one. Yeah. So if anyone's got anything that they want to chip in with, like, please feel free to butt in. And yeah, I think, where do I go? View, present, okay. Just one more come in now. Chris is here. Hi, Chris. I'm just going to mute that. And another one. Hi, Dan. Just for those people who've just come in, this is what the presentation is going to be on. And yeah, I'm just going to crack on. Otherwise, I'm going to keep introducing everyone. Just jump in whenever you feel the need to. Okay. Yeah. So spondyloarthropathy, it comes under rheumatology, which is the study of rheumatic diseases. So diseases that are caused by immune disorders, and an umbrella term, so spondyloarthropathy is an umbrella term for autoimmune inflammatory conditions affecting the axial skeleton, so the spine and the SI joints, and to some extent the costochondral joints and the costovertebral joints, and also peripheral joints. So it includes the following conditions: ankylosing spondylitis, psoriatic arthritis, and reactive arthritis. Rheumatoid arthritis and gout also come under rheumatology, but they do not fall under spondyloarthropathy as an umbrella term. So this presentation is really focusing on axial spondyloarthritis, so AXSPA. So that's an inflammatory conditioning affecting the joints in the vertebral column. Causes progressive pain and stiffness in the long term, causing irreversible fusion of these joints, and is known to be related to the HLA-B27 gene. So 90% of patients with spondyloarthritis do have the HLA-B27 gene, but conversely, only 2% of people with HLA-B27 will actually develop spondyloarthritis. You may have heard it being known as ankylosing spondylitis before. So the new term just encompasses ankylosing spondylitis and also patients with clinical disease, but without radiographic findings. So yeah, the prevalence is actually pretty high, 0.5 to 1% of the population, which is the same prevalence as MS, but it's not as well known, not as well funded by charities, and it's much more commonly missed. So it's more common in men and women, and the main presenting complaint is back pain. So we're very likely to see this in clinic. Symptom presentation is highly variable, particularly in women more so than in men. And there's no diagnostic physical examination or test to rule it in or out. The average delay to diagnosis is 8.5 years, and that has a massive effect on outcomes. The delay to diagnosis is actually more for women than it is for men, and that's just due to the symptom presentation being highly variable. So yeah, almost all outcomes are negatively associated with the delay to diagnosis, and that is because the chronic inflammation causes irreversible damage to the spine. So yeah, our increasing roles in primary care and our FCP roles, just being aware of spondyloarthritis as a condition, and being aware of the signs and symptoms and knowledge of referral pathways just becomes more important for us, I think. Okay, so I think subjective history is probably where you're going to figure out, or it's information from the subjective history that is going to be raising your index of suspicion of someone having something like spondyloarthritis. So digging through their past medical history, trying to figure out if they have sort of extra-articular manifestations, so other inflammatory diseases such as Crohn's or colitis, psoriasis, so skin, uveitis, so that's the eyes, usually redness or soreness of the eyes. And then if they've got multiple sites of tendon pain as well, so the most common site is Achilles tendinopathy. It's also very common for these patients to present with things like plantar fasciitis, and patellar tendinopathy as well as the second most common tendinopathy. As I mentioned earlier, the gene HLA-B27 is highly linked to spondyloarthritis, so check the family history. Usually they'll have a close relative, so mum, dad, brother or sister, who have inflammatory arthritis as well. Yeah, so it's insidious onset back pain, meaning more than 3 months they've had it, and onset prior to 40 or 45 years, with the peak onset being actually around 24 years. Most people aren't diagnosed until their 30s though. It has a positive response to anti-inflammatories and morning stiffness that's lasting longer than 30 minutes. It responds well to exercise and movement, and yeah, night pain is a common problem with these. So you might actually think, looking at subjective history, well, regular mechanical back pain is insidious onset usually, and you can find people with onset prior to 40 to 45 years as well that have just mechanical back pain. Morning stiffness, this is something that you just want to dig a little bit deeper. So if they say that, oh, they're feeling stiff in the morning, dig a little bit deeper. Is it lasting sort of 15 minutes when they get moving? Does it ease off? Or is it, you know, actually, no, they have to do a couple of stretches and they feel like actually by the time they've got out of the house in the morning, it's feeling better. One good indicator of someone actually having a spondyloarthritis is if they offer the word stiffness in the subjective assessment. So yeah, try and ask them how they're feeling in the morning, maybe without giving them the word stiffness, see if they offer it as a word. And night pain as well. So you'd want to dig a little bit deeper if they tell you they've got night pain. We've all had patients that have night pain and it wakes them up in the night. So dig a little bit deeper. What are they having to do? Can they just roll over and they feel their back pain's much better and they can get comfortable and go back to sleep? Or are they having to get out of bed, do some stretches, and then get back in? It's usually the second half of the night, so between 2 to 4 a.m. and that's to do with our like immune response. So our immune system quietens down when we first go to sleep. So in the first half of the night, it's quite slow and it settles, and then it spikes again. So our immune activity spikes around 2 to 4 a.m. In order to kind of get us ready for the day. So that's why night pain usually comes on around the second half of the night. Okay. So this is a tool that I found. I can't remember who actually offered it. I think it's at the bottom, a physio called Kerwin. So yeah, it just breaks it down quite nicely if you're needing like a few prompts for your subjective assessment. So screened them, S standing for skin, so check if they've got any sort of psoriasis or skin disease. 6 to 42%, which is a huge variation. I don't know where they got that from, but yeah. Colitis or Crohn's, so it's estimated that 26% of patients who have Crohn's will develop spondyloarthritis at 6-year follow-up, which is huge. It's like quarter. So always check that. Relatives again, so checking if they have any close family members with any sort of inflammatory condition. The HLA-B27 gene is a high indicator. E for eyes, so uveitis and idiopathic. No, it's 40% of patients with idiopathic uveitis have undiagnosed spondyloarthritis. So that's quite a big one, a big clue. Early morning stiffness, we've spoken about. Nails, so have a look at their fingers and their nails if they're actually there with you. If you're not sure, just ask them, like, what are your nails like? Are they in good condition? Usually ridges and stuff that you get in them, small depressions or thickening. Dactylitis is like the sausage swelling of the fingers, so the tips of the fingers will look really big and strange. Enthesitis, again, Achilles tendinopathies, patellar tendinopathies. If someone's had more than sort of 1 or 2 tendinopathies in a year, that would raise your index of suspicion. And then positive response to movement and medication. So because of the inflammatory component of spondyloarthritis, they tend to improve with movement and medication being sort of non-steroid or anti-inflammatories. Okay, so if you are working in FCP, I've sort of done a little bit about what sort of objective markers you'd look for, so what sort of blood tests you'd send for and things like that. Obviously, if you're in just primary care, then you would refer them back to the GP, perhaps write a note to the GP just saying that you found some things in the subjective, and you are querying a inflammatory arthritis and you believe that so-and-so blood tests perhaps should be done. Try not to step on anybody's toes, I guess. So inflammatory markers, they're not very specific blood tests, but they're obviously easily available and they're not very expensive either. So you will find that the ESR and the CRP are raised in inflammatory arthropathies, but lots of other things can cause increased levels of inflammatory markers in the blood. So I didn't know this, but obesity can cause inflammatory markers to be raised. Obviously, acute injury and infection. So again, a positive test wouldn't rule it in, but it's just building that index of suspicion again. If they came back with sort of positive tests, and you'd then probably want to do some immunological tests. So these actually are available. I've had a look on EMIS when you're requesting blood tests. So first you'd look at sort of the rheumatoid factor. So sensitivity is much more sensitive, but then what's he missing? No, I've lost it. Oh yeah, 15 to 20% of rheumatoid factor positive patients have no associated conditions, so it's not completely sensitive. And these ones actually also give an idea of what the outcome's going to be like as well. Anticyclic citrulinated peptide, the anti-CCP, is highly specific for diagnosing rheumatoid arthritis. And then there's that gene again. So it's present in roughly 8% of the population, but highly present in those with diagnosed SPA, so worth checking. Imaging. So MRI is the imaging modality of choice for spondyloarthritis. And you'd want to make sure that you've like passed it on to the doctors and they've spoken to radiology and whatnot to get the right sort of reporting on that as well. X-rays are not very good at diagnosing a spondyloarthritis because not everyone develops radiographic evidence. And those that do won't show up for sort of 8 to 10 years. So you want to get in before then, really. Okay, so this, I'll put a link to the full poster at the end of the slides, but a really good sort of infographic by the BMJ and the National Ankylosing Spondylitis Association, or NAS, I can't remember what it stands for. And if you're suspecting that someone's got an axial spondyloarthritis, you'd probably want to check that they've got at least 3 of these referral criteria before checking the HLA B27. Or if they've got 4 or more of these referral criteria, refer straight to a rheumatologist for further diagnostic assessment. Yeah, I'll put the full poster on at the end so you guys can have a look. Okay, and then primary care management of spondyloarthropathy. So the pharmacological management, so non-steroidal anti-inflammatories, that's to help with the inflammatory pain that these patients suffer with. And then DMARDs, which stands for disease-modifying anti-rheumatic drugs, I think. You can have both standard and biological. I did look into the whole pharmacological management, but honestly, it's not my area of expertise. So if I was worried of someone's pain management, I would just send them back to either their rheumatologist or the GP. What's more specific to us is the non-pharmacological management. So I think exercise is by far the most important management, combined with effective medication. Exercise capacity does increase with effective medication due to pain management, so they kind of work hand in hand. And the exercises really depend on the individual. It obviously needs to suit the individual, their needs and their lifestyle. So whatever you can get them to do, but they should be doing something every day. And I downloaded the app. So NAS actually have an app, it's called Back to Action. I downloaded it. I'll admit I haven't had a chance to actually look through it yet. But there's a whole app completely free of charge, and that's developed by NAS. And they also have they help people who have ankylosing spondylitis like access things like gyms and hydrotherapy and stuff. So if you're ever not sure of what's available in your area, have a look on NAS or signpost your patients to that website, and they should be able to find what is available in their area. And then also consider developing a flare management plan. So do they have some non-steroidal anti-inflammatories that they take when they're in a flare, something stronger? Do they reduce the amount of sort of higher impact exercise that they do and switch to more hydrotherapy, or switch to more sort of stretching rather than like resistance? Yeah, so really trying to empower the patient and sort of help them to take responsibility of what's going on and their condition. And then pain management. So it's sort of multifaceted, and it's based on the individual and their needs, but they're going to be having a few different types of pain. Firstly, the inflammatory pain, and that's due to the chronic inflammation that's going on. Secondly, mechanical pain due to the stiffening of ligaments and tendons supporting the spine and the axial skeleton. And then, as we mentioned earlier, the delay to diagnosis is roughly sort of 8.5 years. So someone who's had pain for that long, it's likely that they've developed some sort of chronic pain. So it's probably useful for these people to also be under a psychologist or someone who can sort of dig a little bit deeper about that, or maybe pain specialists. But I know that resources are kind of spread thinly at the moment. Yeah, I think that's the end of it. Does anybody have any questions, or, for example, has anyone tried referring to rheumatology recently? What has their experience been with that, FCPs? Just put this up.
I had a question.
Who's that?
I had a question.
Yeah.
So, what would you expect to find on the MRI, or would you like specify like, oh yeah, you're suspecting
I don't know who's talking, but they keep cutting out.
That's Dan.
Hang on, I'll just
Hey, Dan.
type it.
Okay.
Dan,
I think I got like half of the question. Like, what would you expect to find on MRI, right?
Yeah.
Yeah. So I had a look at all the research, and honestly, again, it's not my area of expertise. I think with MRI, you start to see sort of bone edema, and you need like the STIR images. So regular MRIs don't often show up the changes that you get in the bone with a spondyloarthritis. So I would imagine when you're requesting an MRI, making sure that in the clinical features you're saying that you're expecting to find some sort of spondyloarthropathy.
Okay.
Yeah, I think it's bone edema is the best answer I've got for that.
Yeah, and also Dan, an early sign can be some fusion around the sacroiliac joints, or some additional bone growth or thickening around the SI joints. But sometimes you don't get to see that sometimes on a lumbar MRI. So if they suspect it, they can scan a little bit lower just to catch the top of the SIJs. But sometimes they have to do a separate sacroiliac scan or sort of a lower lumbar scan to pick that up. And also in advanced cases, you'd probably see a fixed flexion or quite a accentuated kyphosis. Depends how advanced it is.
Yeah, they call it bamboo spine, don't they? When it's like really late stages, when it's become completely fixed, they lose like lots of the curvature in their lumbar, and some in the thoracic as well. But yeah, that's more sort of late stages. Yeah, hopefully you'd have found it by then.
Okay. And is there any particular exercise that would be best for them, or just whatever they can do to just mobilize the back kind of thing?
I think mobility is a big part of it. So both hip and lumbar spine and thoracic mobility, focusing a lot on rotation, external, internal rotation at the hips, lumbopelvic control as well. I think a lot of people with SPA find that swimming is really good because you get lots of rotation through the back and through resistance when you're doing strokes. And then as well with breaststroke, you're getting lots of external rotation at the hips. And then the water is just like pain relieving as well. But really, it's just finding something that fits into someone's everyday life as well.
Cool. Awesome. Thanks so much.
That's all right.
I'd also add, I'm not sure you mentioned it, but there's a very strong family history predisposition with the ankylosing spondylitis. So you'll often see a history of and sometimes it skips a generation, but sometimes mum or dad, or especially grandparents, will have had symptoms that look like rheumatoid arthritis or polymyalgia rheumaticus type rheumatoid type conditions, or ankyspon as well. So asking family history in the history is really, really useful during the assessment. Yeah.
I don't know what it's like in your area, guys, but I tried to refer someone. It wasn't for SPA, it was for suspected rheumatoid arthritis. And I've referred this guy from FCP back in June, and he's still not heard anything yet. Have you guys realised or noticed any sort of delay referral at the moment, or have any first-hand experience with that?
No, not sure.
No. Okay.
Joe, have you seen Joe's question?
Where's that?
in the chat. I'd read it out. If there's such a delay in diagnosis, is there a chance you can still get patients over 45 who can present with these symptoms? And would they still fulfill criteria for testing or referral to rheumatology? I can help you answer that if it
Yeah,
helps.
go for it, Tim. Yeah.
Yeah, so I mean, my experience of ankylosing spondylitis, which is most common of these, is it usually starts happening in the early 20s. And so you're aware that they usually have a degree of stiffness more than one would expect. And they usually do get tested, sent to a rheumatologist and get tested, and they usually come up positive on HLA-B27. And that's a pretty strong. I know that actually I didn't realise, but Katie said that 8% of the population or whatever naturally have HLA-B27. I had no idea, but if they put 2 and 2 together, that's a pretty strong diagnosis for ankyspon. So you don't get to see that many. I don't tend to see people aged 45 that haven't been diagnosed with it. But yeah, you could still refer them to rheumatology and go through the tests, especially if they're not responding to management, exercise therapy, physiotherapy, osteopathy, etc.
Just on the chat.
Yeah.
Okay, cool. Oh, so Will was saying that wait time FCP one's worth about 3 months at the moment for rheumatology. Yeah. Yeah. I think DXS also has all like the referral pathways and stuff, doesn't it, Tim? Do you guys have DXS in?
Yeah, we use DXS in Croydon, not in Lambeth or Wandsworth.
Okay. Yeah.
But yeah, I'm just trying to think how we referred to I think rheumatology referred to SK Cats and request rheumatology on the referral in Croydon. I don't think I ever referred anyone to rheumatology when I was doing FCP. So
yeah.
All right, Kate, is there any more questions, anyone? Good. Well, Katie, thank you so much for doing it.
No trouble at all.
I think, Chris, you and me are probably going to work on the next one in 2 weeks. Have you got any ideas what we should do, Chris? Or was there any requests out there?
Yesterday, I had about 5 or 6 wrist patients in a row, which was quite challenging to have a whole bunch of, those non-specific, nothing really happened wrist pains, which got me doing a bit of research into it. So I don't know if that would be helpful for anyone, if we dig into a bit of wrist pain and Dequa veins and triangular fibrocartilage stuff and all those tricky things. Being a sports physio, working with rugby, wrist was never my big deal. It was always just a lot of strap and play kind of situation with the boys. So yeah, it would be a good thing for me to do a bit of review into that. I'm seeing Katie nodding.
Yeah, I'll be happy to.
Yeah, sounds great.
Yeah, let's do that, Chris. 2 weeks time, wrist injuries. Brilliant. Katie, amazing job. Thanks so much. If you can please Dropbox me, or we transfer the file and we'll put it on the internet.
Yeah.
And yeah, fantastic work, and thanks so much for doing it.
No trouble. Thanks for listening, guys.
Thanks so much,
Take care, everyone.
Thank
Right.
you.
Good evening.
Bye.
Bye.
Take care.